Once again, thank you, sir. Uh, I'll be talking in next few minutes. And my topic is the scleral buckling art is dying. This is my first patient, which has been I operated in 2001, underwent the scleral buckling procedure, and you see good retina is well attached with the good indentation of the buckle. Uh, the another patient which underwent a surgery in 2003 now developed mature cataract. On the B scan, retina is attached and there is a good indentation. The scleral buckling procedure is considered as a gold standard for the reattachment of the retina since more than 6 to 7 decades. Besides closing the underlying retinal break, local indentation provided by buckle, it relieves the centripetal vitreoretinal traction and encircling element reduce the transvitreal tractions. The advantage with the buckle are they are extraocular if we are not draining. It can support the missed break in the periphery. It is very effective in the retinal dialysis. We are not touching the crystalline lens and so the accommodation is preserved and the equipment and personal cost is lower with scleral buckling. But there are certain drawbacks with the scleral buckling, like there is increased post-op morbidity like pain or periorbital edema. There are drainage-related complications are there. Buccal infection, extrusion or formation of ERM is there. The single surgery success rate has been reported more than 85 to 90% or in some series more than 95%. But in the last few decades, pars plana vitrectomy has become an effective procedure to fix the detached retina. The advantage with vitrectomy is we can directly visualize the vitreous traction. We can directly eliminate the vitreous traction and we can reduce the vitreous, so the risk of PVR is less. The another advantage is the improvement, it improved the internal search for the retinal break in the peripheral retina. The other advantages are that we can remove the complete removal of media opacity. It is a shorter surgical time and the lower post-op inflammation and the faster recovery. With the availability at the 23, 25 and now 27 gauge instrumentation, and wide angle viewing system with the high speed cutter rate, the vitrectomy is much easier and single surgery success rate is almost 20%. The drawback with vitrectomy is the rate of cataract formation increase, iatrogenic retinal break, higher cost and second surgery if we are using the silicone oil as a tamponade. In last 1 or 2 decades, the general trend is shifting from scleral buckling towards the vitrectomy for the treatment of uncomplicated primary recombinant lesions, and it is increasing. The question is, in the era of micro-incisional vitreal surgery, the scleral buckling art is dying? Let's see how literature say about it. In various series, the single operation success rate is better with the vitrectomy, but in others, this is the scleral buckling. Although in phakic eye, scleral buckle was reported equivalent or even superior to pars plana vitrectomy, while in pseudophakic eye, vitrectomy was better. In SPR studies, it is a prospective randomized trial that compared buckle with vitrectomy has found the visual benefit for the scleral buckling in phakic eye. In pseudophakic eye, there was no significant difference in the visual benefit, but based on the better anatomical outcome, the vitrectomy was recommended the use in the pseudophakic patient. Similar result was seen in AVRS studies also. In spite of the fact the buckle is having almost equal success rate in uncomplicated RD, it is cheaper option. Like in Ayushman Bharat also, the buckle has been allotted 15,000 rupees as compared to 17,500 for vitrectomy. And as we know, the cost of packs in between range between 22 to 27,000. The trend is shifting towards the vitrectomy. The probable reason for the change are availability of the small gauge instrumentation, wide field viewing system, high speed cutter and better illumination made vitrectomy much easier. Surgeon lack confidence in their skill with indirect ophthalmoscope, less time spent on buckle by a mentor and training program, and no industry support for the buckle. At our center, scleral buckling surgery is the choice of surgery for RD. A retinal break can be buckled. As we feel it is extraocular surgery, there is no risk of cataract formation and it is a cost effective. To conclude, scleral buckling certainly continue to deserve a place in armamentarium for RD